It's imaging of tuberculosis. So remember, this is the case that we started off with last time. A 35-year-old male who had loss of appetite, loss of weight, fever, and storage symptoms, and who had taken ATT for many years ago. We told why this particular organism is remaining dormant inside. What are the various methods of pathogenesis, the Mendel's concept, Deaky-Horn's hypothesis, Cohnheim's elimination theory, Weilbohl's unified theory of GOTB. All that we discussed. Next slide, all that we discussed last time. And this is the recap of the previous. Next slide, please. The first thing that we normally do after we examine a patient is take him to the next room because ultrasound to do an ultrasound, because ultrasound is nothing but an extension of a clinical examination. Ultrasound and uroflowmetry these days are considered to be extensions of our clinical examination because they both become an integral part of urological armamentarium. So any patient who walks into our urology outpatient clinic will get any of these tests done straight away. So what you see here, there's an ultrasound of the abdomen of a patient with a GOTV. You can see that the calyces are dilated, and you should see that the individual calyces are individually dilated and they are not communicating with the uh, centrally dilated system. Okay, this is one of the hallmark of genitourinary tuberculosis. One calyx is a little more enlarged, the other calyx is a little less dilated. So there is an asymmetrical dilatation that you can see arrow marks or white arrow marks. The one on the top left, you can see that the individual calyces are standing at prominent, not communicating with the collecting system. Whereas the one bottom right, you see each of there's a global hydronephrosis and there is a hydropelvis also. The pelvis and the pelvic calyceal system on the whole is dilated so that there is a global hydronephrosis. This will tell you where exactly the pathology is. The way the system is dilated will tell you where the pathology is. The first one, the top left corner, that particular image shows that each of the infundibula was narrow and the pelvis is not dilated. The one in the line in the bottom right shows that there is a distal obstruction either at the pelviureteric junction or further below, lower down in the ureter, which causes a global hydroureteronephrosis. So by this ultrasound finding itself, you will know whether the system is actually blocked at infundibulum level or at the pelviureter junction level or at the ureter. Next slide. So this information you will first get with your ultrasound. That's the first information that you get with your ultrasound. The ultrasound, there are certain findings of GUTB. The earliest finding will be a small cortical granuloma. That's the earliest finding, and then the granuloma will slowly progress and then distort the entire parenchyma. And then it becomes a mass. It becomes an abscess finally. Then the kidney becomes a little chronic inflammation. It will produce a shrunken kidney, and that will also affect the other parts of the genital, that is the ureter and the bladder also can get affected. So the ultrasound findings of GATB include all this. Please remember that the parenchyma need not be thinned out in all these individuals. There is a possibility that the parenchyma may be thick also because the pathology is at the level of obliterative endarteritis. The actual pathology is obliterative endarteritis, which occurs at the level of the interlobular artery. The interlobular arteries on the major calyces. They branch out to each of the minor calyces as interlobular arteries. These interlobular arteries will run on either sides of the infundibulum, and the bacteria which are lodged in the cortex, they will actually dump into the interlobular arteries, and from there only the pathology will start. The obliterative endarteritis happens at that level on either side of the infundibulum. So the infundibula gets inflamed, and then it becomes edematous, and then it gets fibrosed, it gets shrunken. There is an infundibular stenosis, which causes individual calyces to stand out prominent. So that is what you should remember as the basic. Next slide, please. We talked about pathology last class, so it's just a continuation of that. This is again another one where you can see a cortical granuloma. You can see some sort of an irregularity of the cortical surface, the cortical granuloma. Okay, the important thing that you should remember is that this is one of the earliest findings in ultrasound, not another CT or IVU. In ultrasound, the earliest. Next slide, please. The earliest finding is a cortical granuloma that you can see. Next slide. You can use high resolution ultrasound images to further characterize what this granuloma is all about. You can, if there are small irregular caseous cavities which are present, that can also be identified with your high resolution. Next slide, please. This high resolution ultrasounds will give so much of clarity. This will be very useful for us. Next slide. This will be very useful for us when we do an ultrasound guided puncture, a nephrostomy when you want to plan, no? So PCN when you want to plan, you can. And it can also sometimes mimic an XGP, the hugely enlarged kidney with some sort of a very nephric inflammation or stranding or whatever can make the kidney appear a little bulky. It can be palpable kidney also that can mimic XGP. Next slide, please. This is again another feature in ultrasound, the densely calcified. You can see the one on the right side. You can see you don't see the kidney at all. That's because the surface is full of calcification. When you have a surface full of calcification, there is a post-acoustic shadowing, and you will not be able to see the kidney at all. It completely obscures the finer details of the kidney. Next slide. We will now move on to intravenous urogram. There are a few important findings. There are a few important findings that you will see in intravenous urogram. IVU is one investigation which has almost become obsolete. I'm very sorry to say and admit the fact that IVU is no more being used by any of the urologists. About 90 to 95% of the urologists are done with the IVU. But in our days, in our post-graduation days, IVU was an integral part of this radiological armamentarium for any urologist for that matter, because CT was being used in a very, very limited manner those days. And IVU had so much of information to give, but unfortunately, not many of us are exposed to IVU. That's the reason why I thought maybe we can run through a few slides to show what exactly the pathology that can be seen in patients with the GUTB in IVU, especially IVU or excretory urography. Okay, this is one X-ray KUB where you can see a calcified kidney. It's called a putty kidney. Do an IVU, the other kidney is opening out fully, completely, whereas this side the kidney is not getting opacified at all. Electric system is not getting opacified. That means the kidney has become non-functional. A non-visualized kidney more likely to be non-functional too, but it is not always like that. Okay, that is one distinction again you'll have to make. Kidney, if it is not visualized in an IVU, does not necessarily mean that the kidney is non-functional. Most of the times it will be non-functional, but it is not necessary that it should be like that all the time. Next slide, please. This is one example of a fuzzy or a feathery calyx. Fuzzy feathery calyx is the earliest finding that you get IVU in a patient with GOTB. Most of the times, what happens is between two minor calyces, the smaller infundibulum of the minor calyces, they are the places where the interlobular arteries. So the primary pathology will actually lie there, and the callus will get eroded, the papilla will get eroded, and the minor calyces will also show some sort of an irregularity, which is called as a fuzzy or feathery calyx, which is the earliest finding that you get in your GOTV. Whereas in ultrasound, if you ask, the earliest finding that you see in ultrasound will be cortical granuloma. The earliest findings that you see in an IVU in patients with GUTB will be, next slide please, fuzzy or a feathery calyx. The other one is a blunted calyx. The once once it becomes eroded, then it gets a little smoothened out, then it becomes a blunted calyx or a moth-eaten calyx. Okay, that becomes a little what just to see what moth-eaten is. The bug will actually eat the leaf. No? That is the appearance that they give. And the moth-eaten calyces. Okay, moth-eaten calyces is again another feature. The blunted calyx or moth-eaten calyces are features of a GUTB. Next slide, please. These pictures we have taken from Polak. Next slide. Moth-eaten, I have shown the leaf on the right side. This is what a moth-eaten leaf is. The calyx, when you do an IVU, will exactly look like that. For fuzzy and irregular calyces. This finding you will also see in patients diabetics with pyelonephritis and renal papillary necrosis. This exact finding will be seen in such individuals also. Okay, next slide, please. The golf ball on a tee appearance. Sometimes what will happen is the collecting system will get so much dilated and the contrast will get into the collecting system. The infundibulum becomes a little narrow. All the contrast will get collected within the all the contrast will get collected within the calyx, and the calyx will be appearing a little globular, and this blunted calyx will appear rounded And that is what you see here on the left side. The picture that you see on the left side, you can see a golf ball, and you can see a supporting stick which will lift up the golf ball from the ground. That is called as a tee. That is called as a golf ball on a tee sign. So, as I had mentioned earlier, this sort of a finding will be also seen in patients with diabetes mellitus, renal papillary necrosis, renal RPN. One of the common causes for renal papillary necrosis is diabetes mellitus. Patients with analgesic nephropathy, sickle cell anemia, obstruction, pyelonephritis, all these patients also can develop renal papillary necrosis, which can also produce a golf on next slide, please, which can also produce a golf ball on a T appearance in IVU. Next slide. Next one is a Kerr kink. A Kerr kink is one where the PUJ gets a little lifted up because of cicatrization, which happens at the level of infundibular. Infundibular fibrosis will pull the renal pelvis up. That will produce a kink at the uretropelvic junction. That is a Kerr kink. Or there is another one in next slide. Other one is called as a hiked up pelvis that can also pull up the pelvis that can produce a hiked up pelvis. This is one multiple infundibular narrowing. Each of the calyces, like what we had seen in the ultrasound, no, the first ultrasound that is shown asymmetrical dilatation of each of the calyces. So the ultrasound will also, so this IV also can show up that sort of picture. We can see here multiple infundibuli are narrowed down as a result of which each of the calyx stands out prominent. Next slide, please. In the phantom calyx, sometimes what happens is that the calyx infundibulum actually will get cut off because of severe infundibular fibrosis. That calyx will get cut off, and the obligatory endarteritis will not allow the contrast to opacify the calyx. So calyx will appear non-existent. That is also phantom calyx. Next slide, please. You all know what a phantom comic is. The hiked up pelvis that I was mentioning earlier, the pelvis is actually tilted up towards the upper calyx infundibulum because the infundibular fibrosis will pull up the renal pelvis and the pelvic junction. So the pelvic junction, there will be a Kerr's kink and there will be an acute angulation at the PUJ because of the infundibular fibrosis which happens at the upper pole, and this upper calyceal infundibulum will retract and pull the pelvis also along with it, and that will produce what is called as a hiked up pelvis. Next slide. Next slide, please. Next. These are various other pictorial representations. Okay. Then the other one is the ureter. Involvement of the ureter can produce what is called sawtoothing. There will be irregular luminal irregularities which will be seen all along the length of the ureter, which is called sawtooth appearance. Next slide. Then pipe stem ureter. You should know what a rigid ureter is, what a pipe stem ureter is. This is classical of tuberculosis. You should know the next slide. You should also know what are all the various differences between schistosomiasis causing damage to ureter and the ureteral involvement in tuberculosis. The differences between the two also you should know. Putty kidney, that one that I had mentioned earlier, this is the end stage of genitourinary tuberculosis. The kidney becomes non-functional, which is called as autonephrectomy. Next slide. We'll move on to the third one. We have finished IVU, we have finished ultrasound. The more important one these days, which we routinely do day in and day out, is CT scan. Okay, role of computer tomography. Next slide. Computer tomography. It's very important for us to see. It's a very common question that is asked in the exam. Some senior examiners who are still fond of doing IVUs will ask you, why not IVU? Why a CT urogram? You should be able to very clearly tell them the differences between IVU and computer tomography, and you should also be able to convince the examiner that the CT urogram has got specific select advantages over an IVU, and CT urogram has almost replaced IVU as the imaging modality of choice. Okay, next slide. The main advantages of a CT urogram over an IVU is that if the kidney is not visualized in IVU, it will not give you any information. Whereas in the CT scan, even if the kidney is non-functioning, even if the kidney is non-functioning, the anatomical delineations can be very well appreciated. the dilated calyces, the thin dot cortex, the small subtle calcifications which you see inside the kidney, all that can be identified with the highest degree of accuracy in a CT scan. And what happens outside the kidney, the perinephric, periureteric, perivesical events, if there's a small urinoma, if there is a cortical abscess, or if there is an extra perinephric collection which is seen extending onto the lateral column fascia, all that information you will not get in your IVU, whereas you can get in your next slide, please. CT scan definitely has got a great role to play, and that is actually replaced IVU as the investigation of choice. As I mentioned earlier, the caseous cavity, some sort of a cavity in the parenchyma will not be seen in the IVU, whereas it can be very well appreciated in the CT scan. Next slide. The subcapsular urinoma. This will be sometimes very hazily seen in IVU, but very clearly appreciated in your CT. You will know how much of urine is collected, and then the volume you can calculate, and also discern whether this means the PCN or a PCD or both. So that decision making also will be the highest level of accuracy if you do a CT scan. Okay, CT urogram. Next slide. An abscess, if it is there, psoas tracking down to the psoas, perinephric and the periureteric events I mentioned. No? All this can be diagnosed with the highest level of accuracy if you do a CT scan. Next slide. The next slide. Yes. So here you can see that the entire kidney is affected on the left side. You can also see the entire ureter getting affected there. And then on top of that, there is something like a stone which is there in the distal ureter. All these are there. If the kidney is non-functioning or if it is non-visualized, none of these factors can be appreciated in IVU, whereas all this information you get. Yes, that's the reason why the exam when they ask you, you can boldly say that CT urogram is the investigation that I would like to do in place of an IVU. Okay, next slide. Moving on to MRI. CT scan definitely has got a greater role to play. Number one, it gives a beautiful delineation of the anatomical description of the kidney. The problem with MRI is that not many of us are still oriented to reading all the T1 weighted and T2 weighted images. MRI has got a definitely greater role to play, but as far as the urologists are concerned not very popular because the readability of MRI is a big question mark. For the urology, we fully rely upon the report that is given to us. Most of the urologists rely on the report that is given to us as far as the MRI is concerned, whereas most of the urologists will be able to read the CT scan and make a decision themselves. So MRI has got a lesser role to play in as far as G2. I'll run through what are all the features that you can appreciate. Next slide, please. So the features you can appreciate in MRI. MRI, as I mentioned earlier, not commonly preferred. It is mainly useful in patients in whom we cannot do a CT urogram. In patients who have got a renal compromised status, patients who have got a higher serum creatinine, in patients who cannot do ionizing radiation exposure like pregnancy, or if a person is allergic to contrast media, you can do MRI. These are three main areas where MRI has got a greater role to play than CT scan. In patients with a higher creatinine, in patients who are pregnant, you cannot expose them to radiation, or in patients who show allergy to contrast media, iodinated contrast media, the best will be to go for a MRI plane because the MRI plane, heat to weighted image of MRI plane itself will give you like a contrast. On top of that, if there is a possibility, then you can do a Gado enhanced MRI also. But even without a Gado enhanced MRI, we'll still be able to get all the adequate information that is required with the plain MRI itself. Next slide, please. Next slide. These are advantages and disadvantages of MRI I've listed. Most of it I've already talked about. So move on to the next slide, please. And the cystoscopy and bladder biopsy. Cystoscopy is not a routine test that we do in patients with GOTB. Most of the times, the decision is taken based on the clinical findings, radiological findings, with or without microbiological documentation or with your CBNAT. Okay, so it's very important for you to decide on who actually needs a cystoscopy, who actually needs a bladder biopsy. If the bladder is inflamed, the patient has got severe pain, suprapubic pain, an inflamed bladder with reduced capacity, doing cystoscopy can sometimes be counterproductive also. Because cystoscopy, when you do in a patient suspected GTB, you have to do it with extreme caution. You have to do it with continuous irrigation. Continuous irrigation, how is it possible? You put a 10 French feeding tube inside the bladder and then take a regular cystoscope sheet, and then you can do that like as a continuous irrigation. Or you should take a 24 or 26, not 24, 24 or 26 continuous irrigation channel and do a cystoscopy for that matter. Okay, so wherever there is a need, wherever there is a doubt, you can always do a cystoscopy with utmost caution, because over distending the bladder can sometimes produce a red glow, after which documenting the findings will be extremely, extremely difficult. Next slide, please. Also, when you do a cystoscopy, if it's an inflamed bladder, the fear of the bladder getting perforated also should be kept in mind. So, avoid over distension of the bladder. This major criteria, minor criteria, I will talk about in detail again when we discuss South Indian consensus. All of you should know what the South Indian consensus conference is all about, what sort of consensus they all arrived at, and what is best suited for the Indian scenario. Most of the documentation has come from the Western world, whereas that is actually not applicable to an Indian scenario. That's the reason why the South Indian Consensus Conference, the team members, urologists headed by Dr. Venugopal and Dr. Ganesh Gopalakrishnan, they came up with some sort of a proposal saying that we can define major criteria, minor criteria, and see if we can get one major or two minor criteria fulfilled in that particular individual, so that we can label them as having GOTB, and you'll be not sued in the court of law if you justify the need for starting the patient on ADT based on this major or minor criteria. The major criteria includes three major criteria. One, as I mentioned, CB not positive. The presence of positive CB naught itself is an indication for starting the patient on ADT. Number two, the bladder biopsy, when you do, if you can see some granulomatous lesion in the biopsy, that itself is sufficient for us to go for an ADT treatment of these individuals. And documenting AFB in urine AFB, granuloma or epithelial granulomas, Langhans cells, presence of all these in the biopsy, or a positive gene expert. These three are major criteria. And if you have any of the major criteria, that's sufficient for you. Or if there are radiological findings suggestive of TB, clinical findings in the form of ESR suggestive of TB, hematuria suggestive of TB, biochemical findings in the form of raised ESR. ESR is very high, 100. We were talking about why ESR is high, above 100 or near 100 in patients with GOTB earlier. And if there are lung changes which are seen in the X-ray chest of treatment of old pulmonary tuberculosis, all these are feasible. If you have clinical findings, if you have radiological findings, if you have biochemical findings, or if you have pulmonary findings suggestive of tuberculosis, two of the findings are criteria are met with, that itself is sufficient for you to start the patient on ATT. Next slide, please.
So there's a query from the participant, sir. Can we start ATT based on radiological finding only? They've asked, sir.
That is what I was mentioning. That is what I was mentioning. Can you put that slide, major criteria, minor criteria slide? Stop here. Okay. See, the radiological findings, if it's a minor criteria. On top of that, you should also know why you want to start the patient on, why you want to do radiological. There should be some clinical correlation. So if you have some findings like hematuria or severe storage, let's giving you a suspicion or family history of tuberculosis, lung changes suggestive of tuberculosis, or raised ESR in these individuals. Along with that, if you have radiological findings suggestive of tuberculosis, then you are licensed enough to start the patient on ADT. That means if you have two minor criteria fulfilled, or one of the major criteria if you have also, you are justified in starting the patient on ADT. I could see Srinivasan sir's presence here. Welcome, Dr. Srinivasan Ganesan. And sir, any comments at this stage for the benefit of the postgraduates? I could see also Dr. P.V. Srinivasan here. Dr. Srinivasan, Dr. P.V. Srinivasan, Dr. Shekhar is there?
Sir, good morning, sir. Srinivasan.
Srinivasan, very good morning. And
Good morning, sir.
I welcome Dr. P.V. Srinivasan, a senior consultant urologist from Pondicherry, and he's a consultant urologist in Kadalur GH, and has got an extensive practice in got trained from GH and has got an extensive experience in treating patients with GUTP. Welcome you, Dr. Srinivasan. And
Thank you, sir. Thank you,
uh,
sir.
any comments to the postgraduates at this level with regards to, I'm sure you would have had maximum experience amongst all of us in treating patients with GUTP, especially in the government setup. And any specific comments? What are the practical problems that you
Actually,
have encountered while treating these
actually,
patients? How
first of all,
success?
I
Yeah.
should thank you for taking so much pain in conducting this program for the sake of postgraduates. It's very nice, sir, and a very good gesture. And the patient, all the postgraduates should take it in good sense, and they have to make use of this. That is very important because person knowing G2B nowadays is less. Because we should have high anticipation to diagnose tuberculosis. So the person like you having extensive knowledge in tuberculosis or less today. So the postgraduates should take the things seriously, and they should get make use of it and get benefited from this. That's the thing I wanted to tell you, sir.
Okay. So did you have, I'm sure you would have been associated with GS during COVID time also. Were there any practical difficulties that you had encountered in getting all these DOTS programs organized, this NTCP and NTEP programs are getting organized? And how difficult was that? If you can share that experience also for the benefit of the postgraduates, that will give some sort of a holistic idea about the magnitude of the problem of GUTB that we're dealing with in today's community.
Actually, the government of India is very keen on picking up patients with tuberculosis, and it's very, very keen in misusing the drugs. So they are very careful, and they are very eager to treat the patients, and they are helping to our doorsteps to take care of the patients. So government is doing very good job. The thing is, we have to pick up the case and correctly we have to refer the patient at the correct time to the district tuberculosis authority. That is the thing. In COVID times, actually, we were all concerned with that main life and death problem. We didn't have much problem in this district tuberculosis management authorities, but it was okay. But one thing I wanted to ask you, after the COVID, a surge in pyelonephritis patients with the urine culture negative, and clinically they presented as pyelonephritis. I do not know what made them to present like that. The urine culture, blood culture, everything will be negative. The incidence of pyelonephritis was very high with the COVID time. That is my experience. Not, I mean, non-diabetic or no comorbidity patients, even young patients, they presented with pyelonephritis like clinical picture, and they settled with 2 or 3 weeks of antibiotics, empirical antibiotics. But the urine culture, blood culture, everything was normal. Is G2B is to do anything with that, sir?
Yes, it's a very, very interesting point that you have raised, Dr. Srinivasan. Yes, actually, the COVID actually threw so much of a surprise on us. We started also getting patients with fungal pyelonephritis. We started getting lots and lots of patients with emphysematous pyelonephritis. I was so shocked to see that during the peak COVID wave, the second wave, the second lockdown, that is the time when we had so much of emphysematous pyelonephritis, flurry of cases we had. For what reason, we don't really know. And these patients had, especially when you have an atypical bacteria like this mycobacteria or a fungus, the routine cultures will be all negative. But these patients had a fungal hyphae in urine. Maybe if you had carefully looked for the urine microscopy, because most of the urine microscopy will not document presence or absence of fungal hyphae. They'll talk about pus cells, they'll talk about pH specific gravity, they talk about RBCs. cast and crystals, but they do not mention about the presence of fungal hyphae. The fungal hyphae, presence of a fungal hyphae may point towards a possible fungal pyelonephritis also where there is a possibility that the routine blood and urine cultures may be negative, but they may be harboring Candida albicans also. That again we saw maybe because the COVID brought down the immunity down to such an extent that all these fungal infections and all the gas forming E. coli or this thing, what is the emphysematous pyelonephritis also so rampant that time. But Ramachandra, as you all know, it's a tertiary care referral center where patients from various parts of the state and from the country with the severe forms of fulminating pyelonephritis do land up at odd hours every day. Almost every day we get 1 or 2 admissions of pyelonephritis, fulminating pyelonephritis getting admitted in our hospital. And of course, there is a regular inflow of such cases. But what I think postgraduates should remember is that COVID brings down the immunity, and the reduced immunity, reduction in immunity will cause an increased incidence of the other atypical forms of pyelonephritis, which Dr. Srinivasan rightly pointed out. We regularly miss out those findings in our routine urine culture and blood culture. I could also see Dr. Srinivasan Ganesan here. So good morning, sir. I welcome you to the program. And any particular, with your extensive experience in overseas, the United Kingdom, if you've got any pearls of wisdom which you can share with us, that is most welcome, sir.
Thanks, Sriram. That's a big revision for me for tuberculosis. So normally we don't we read only when we suppose the number of cases are not very high. So we tend to read only when we get a case. So this is a big revision for me. So I don't have to go back into textbooks to read all about the details of tuberculosis. It's a very, very useful and learning experience. And this South Indian urologist, this is a very big move because in India it's different story compared to the West. In West, the referral pattern is very clear. We don't have to break our head on all these things. For suppose we do not know the dose of a drug, we can boldly refer BNF, British National Pharmacy, in front of the patient. In fact, writing a medication with a wrong dose is a serious crime there. So we are supposed to refer to the BNF and write, and the patient is also convinced. We are also sure, patient is also convinced. That's how it works there. But here, when we look at the book or the phone in front of the patient, patients think that we are not, doctor is not very well versed in the area. That's the unfortunate situation here. But these things are changing. So it's better to refer and write the correct dose and medication rather than, because in the West, it's a drop-down menu. So you don't have to, suppose there's ciprofloxacin, you can't write 100 milligram. It is at 250 or 500. So writing a wrong dose, a wrong drug is very, very unusual there because the system is like that. Here the system is different, so we need to be a little more cautious in selecting the medication and the dosage of the drug. More than anything, the diagnosis matters. How you suspect the disease, how you investigate and how we tend to diagnose tuberculosis is more important because the level of suspicion should be very high. Otherwise, we tend to miss out all these easily tuberculosis cases. Yeah, thank you.
Thank you, sir. Thank you for your valuable inputs. As Dr. Srinivasan is a senior most urologist here, and as he rightly pointed out, the dosage is very important because inadequate dosage, if you give, the chances of one developing a drug resistance, drug resistance as well as bacterial persistence or infection is much, much higher. And that's the reason why they say not just one drug with appropriate dose, especially when you're treating a multi-drug, treat them with 4 or 5 drugs and hit the bug really, really hard enough for that to get eradicated. You aim at eradication, you aim at elimination, not just at controlling tuberculosis. With that background, Venkatesh, yes, Aravind is there. Aravind, I can see Aravind also. Aravind, would you like to share anything at this point of time or like to? Okay.
Hello, sir. Can you hear me?
Yeah.
I'm
Dr. Venu Reddy.
Yeah, Venugopal Reddy. I was assistant professor in Mizoram.
Wonderful. Yeah.
In general surgery, and I am the master trainer for NTEP guidelines on extrapulmonary tuberculosis management.
Amazing.
And
Wonderful.
I attended both November session 2023 as well as in AIMS, where we finalized material for extrapulmonary tuberculosis.
Great.
And in the last year in Bangalore also, I am the one of the panel member for especially GUTB for state level training. Currently, I am taking on doing my MCH urology in Meenakshi Medical College.
Which Kanchipuram is it?
Yes, sir, Kanchipuram, sir.
Oh, okay.
I took education from Mizoram government and I joined here.
Okay.
One thing I want to highlight is in this GUTB, currently, even from the NTP guidelines also, urine sample and stool sample are the two where CBNAT is not possible. So because of that, what they suggested is whenever we are doing any CBNAT on urine sample, to do a centrifugation and precipitate only has to be done so that the result will be more accurate.
Wonderful. Okay.
And the treatment also is now the NTP guidelines and newest guidelines for EPTB management. Also, they are suggesting only for 6 months. 6 months. If it's not responding, we have to rule out the resistance. So that is what 2 points I want to highlight, sir. Yeah.
Great. Thank you so much, Dr. Venugopal Reddy. Thank you so much for joining us and patiently listening to the session. And I was just wondering how you came to know about this activity that is happening today.
Sir, I am in one WhatsApp group, sir.
Oh, really? Wonderful, wonderful.
Posted everything and I register also in that.
Oh, thank you so much.
Thank you so much, sir. It's so informative for us and help us for our exams also.
Yes, thank you. Thank you so much. And shall we move on to the next topic, that is medical management, Venkatesh?
Yes, sir. Yes.